Our next speaker is Professor Adam Mead from Oxford University Hospitals. Adam has been amazing support to, well, starting with MPD and now MPN, and I give you a real welcome to talk about Mithridate and the need for the clinical trial. Thank you, Adam.
Well, thanks very much. Always wonderful to be here. Such a packed room. Brilliant meeting organised by MPN Voice. Such a pleasure to be here. Thank you. So I'm going to talk about the Mithridate trial today and why it's important. But on the first slide, I just want to take you through a kind of timeline of MPN, just some calls for reflection in this slide, and that we've come a long way in many ways from when the MPNs were first described back in 1951. Lots of molecular discoveries along the way. In particular, probably the most important in my career is the discovery of the JAK2 mutation by various groups around the world, leading to the discovery of JAK2 inhibitor treatments. On the other side, here's hydroxycarbamide. This is the most commonly used treatment still in persons with MPN, and we've been using it for, 60 years pretty much. So, it's still a good treatment, but, that does raise the question, is there anything that we can do to improve on that treatment that we've been using for so many decades already? And that's what I want to focus on today, particularly in the context of patients with polycythemia vera. So if we think about polycythemia vera as a diagnosis and think about the management of the condition, what are the goals that we're aiming for? Well, I would put that into three different categories. First of all, to reduce the risk of complications, thrombotic, vascular, bleeding problems, improve symptoms, and minimize the risk of the disease progressing to more advanced forms of MPN or other types of blood cancer. So those are the three goals that we should keep in mind as we think about the different treatments that I'm going to talk about today. So one thing that often gets asked in clinic is, why is the hematocrit level so important in persons with polycythemia vera? How is that established, this 0.45 target that we try and get below? And this was established actually most definitively fairly recently in a study called the CYTO-PV study led by Tiziano Barbui and colleagues. And there they randomized patients between aiming for a really strict hematocrit target of below 0.45 versus a more relaxed target of between 0.45 and 0.5. And you can see that patients where we were aiming for a really strict control of the hematocrit had a lower incidence of serious complications of the disease compared to those where we had a more relaxed approach. So that really definitively establishes controlling the hematocrit as a key goal in the treatment in PV. And by controlling the hematocrit, you can reduce the risk of complications of the disease. Second thing to say is risk stratification is important. Most patients with polycythemia vera will be classified as high risk purely on the basis of age, but some patients have so-called low-risk disease that can be managed just with aspirin and regular venesection. But it's worth bearing in mind there are some factors that can place lower-risk patients into a higher risk group, for example, a very high platelet count, high white blood cell count, or if they have other cardiovascular risk factors. But if we think about patients with high-risk disease, the standard treatment is not only low-dose aspirin and venesection to control the hematocrit level initially, but then cytoreductive treatment. And for the cytoreductive treatment, there's essentially two choices at the moment. One is hydroxycarbamide and the other interferon. And it's worth reflecting that, that's quite a complicated discussion to have at diagnosis, actually, when you're choosing these two treatments, because they're two agents with totally different routes of administration, side effect profiles, long-term consequences, long-term disease control profile. So that can be quite a nuanced and complicated decision to make. But the reality is, at the moment, hydroxycarbamide remains the typical first-line cytoreductive treatment in PV in the UK and across the world. So what are the limitations of hydroxycarbamide? Many of you will be taking hydroxycarbamide. It's a very effective drug for controlling blood counts, but it has limitations. And that is, broadly speaking, falls into two different groups. One, people can become resistant to hydroxycarbamide, and two, people can develop side effects that mean they're unable to take it. And overall, that's about a quarter of people who start hydroxycarbamide, that one of those two things happen. And people with resistance in particular have got less good outcomes compared to those who don't have resistant disease. So that is a really important group with an unmet need where we need to improve treatments. And that's when we get to ruxolitinib, the JAK2 inhibitor. So nearly all of patients with polycythemia vera carry this mutation in this gene called JAK2 that signals inside the cell and sets the bone marrow factory off on this kind of unrestricted kind of proliferation, overproducing blood cells. And ruxolitinib was designed to kind of sit in this pocket that's damaged by the JAK2 and prevent it from causing this uncontrolled proliferation. So a few years ago, in fact, it was 2009, we started discussing the MAGIC study, which was addressing the question, does ruxolitinib improve long-term outcomes for people with this hydroxycarbamide-resistant intolerant PV? So I'll talk through that over the next few slides. This was reported and published finally last year, which worth reflecting, you know, that's 14 years after really starting to think about the study. Delivering these long-term studies takes many years, actually, but it's been a hugely impactful study led in the UK by Claire Harrison. So patients with hydroxycarbamide-resistant ET, but here polycythemia vera, were randomized to best available therapy versus ruxolitinib, and importantly, followed up for 5 years without any crossover between the two. So that allowed us to assess the long-term benefit of ruxolitinib in this disease group and measure blood count control and other response criteria that we'll get to. And a very clear-cut result in favor of ruxolitinib in this group. So higher chance of getting good control of the blood counts, keeping that hematocrit level down, and the other blood counts under control. And those responses, when they occurred, were much more durable with ruxolitinib compared to the other treatment. So a clear positive result. But even more importantly, because in a way this is a surrogate for reducing the risk of complications. So do we actually reduce complications? And the answer is yes. Event-free survival measured as a composite endpoint of risk of blood clots, bleeding problems, progression to more advanced forms of MPN or death, ruxolitinib was superior to best available therapy, quite clearly so. So that really establishes this as a really effective treatment in this setting. And ruxolitinib superior for control of symptoms, again, durable over prolonged periods of time compared to best available therapy. So it's hitting a lot of those key kind of treatment goals that I outlined at the beginning. I think Jen is going to talk about molecular responses shortly, so I won't dwell on this, just to say this is the chance of reducing the level of the JAK2 mutation with time on the study, and you can see there's a lot of blue down here in this so-called waterfall plot. That means the level of JAK2 is dropping quite impressively more frequently with ruxolitinib than other treatments. And that's important because if you reduce the level of JAK2, that is also associated with markedly improved long-term event-free survival, so reducing the risk of complications of the condition. So a clear-cut benefit of ruxolitinib in this disease setting for all these key treatment goals. And now, you know, raising the question that Jen will talk about in more detail, should we also have a treatment goal of molecular response? But following that, the question arises, should we be using ruxolitinib even earlier in the disease course rather than putting people on hydroxychloroquine and waiting until in some people there might be a problem with resistance? Should we use it right at the beginning? And that's where the Mithridate study was born. And it's worth, there's been a number of learning points. The study is still, of course, ongoing, but there's already been a number of learning points that Claire reflected on yesterday. One of them being, don't plan a large international France-UK study just before Brexit. Don't plan it before there's about to be a global pandemic. Don't plan it when there might be an international shortage of interferon happening. All of which we've managed to address. And the interferon issue, I think, is going to get talked about in a bit more detail later, but I will just mention there's a clear plan for interferon on the study. Patients can get access to the new form of interferon, Besremi, so it should not interfere with the running of this study at all. Okay, so the Mithridate study is now asking the question, and again, a randomized study. If I talked at the beginning about the choice, the difficult choice of should someone start on interferon or hydroxychloroquine. The really nice and innovative design of this study is that at the beginning, when you're thinking about the study with your doctor, you will make a choice together as to whether you would be someone that would start on interferon or someone that starts on hydroxychloroquine. And once that decision is made, then you get randomized to either that choice or ruxolitinib treatment. So it allows you to get the best available current therapy, but also it's the only way to access this JAK inhibitor treatment in polycythemia vera as a first-line treatment at the present time, because it's only funded in the NHS at the moment for people who develop resistance to hydroxychloroquine or intolerance. So this is a study for high-risk polycythemia vera. I talked about how that's defined before. Here, we're defining it as age over 60, any prior history of disease-related blood clots, vascular events, bleeding problems, high platelet count over 1,000, or a history of vascular problems. Really important this, it's not only for people who have just been diagnosed. You can actually have the diagnosis for a long time and even have been on one of these two treatments for under 10 years and still enter the study and be randomized. The Mithridate team, it's being led in the UK by Professor Harrison, led in France by Professor Kilagian, and there's a whole team led by the sponsor, the University of Birmingham. We're doing a lot of associated sample collection and biobanking that will just be an incredible resource for future scientific studies over the coming years. So there's very good capture and representation of sites all across the UK. We're aiming for 55 sites. There's still some sites opening, but at the moment there's 47 sites open. The study is still recruiting and will be recruiting for quite some time. But if you think this might be a study you would be interested in taking part, you should have a site reasonably close by to make it feasible. This is the full list of the inclusion criteria. They're pretty flexible, and we try and make it as close as possible to the standard of care so that the study visits are not too cumbersome. So initially there's quite regular visits, but there always will be when you start on a new treatment for polycythemia vera, but quite quickly it moves to a study visit once every 3 months. As I mentioned, there's extensive banking of blood and occasional bone marrow samples that, if you've already had a bone marrow test, you may not need that repeating again, because it's not a nice test to have done. But these will have the ability to really build up a resource of samples where we can do laboratory-based research to learn more. And I think in the next talk, you're going to hear about a really interesting study where we're studying skin toxicities of the treatment and skin samples and really trying to understand why some people with MPN and people on MPN treatments are at increased risk of problems with their skin. So this is where we're up to with the study at the moment. I mean, it's an incredible achievement already that there's been over 180 patients, making it one of the biggest studies in polycythemia ever conducted. We're recruiting approximately 10 patients per month on average, but there's still quite a way to go in the UK and quite a bit further in France to go. So this is a study that's going to be continued over the coming year at least, and probably quite a bit longer. So I'm not going to talk through these because I think my time is up, but it's just summarizing what I've just said. The key thing is we're very grateful to anyone that's taking part in the study because it's really going to advance our understanding and move forward treatments for polycythemia. Thank you very much.